So I see the attendee counter going up. So we're going to give everybody another minute to join, and then we'll get started at about 1:32 Eastern time. Welcome, everybody. My name is Shoma Ghosh. I am an Associate Vice President within the Behavioral Health Practice at WestAT, and I'm part of the leadership team of the SAMHSA Center for Financing Reform and Innovations contract. I have dedicated the last 2 decades of my career trying to improve the behavioral health services of this country, and the topic of today's webinar really exemplifies the progress we've made in addressing the opioid epidemic and alcohol use disorders. We had over 1,800 people register for this webinar, so we're very excited, and you'll see the participants joining as we go along. And so while we're waiting for everybody to get on, I'd like to cover a few housekeeping items. The first is you'll notice that there's a chat and a Q&A console on your webinar platform. On the chat, I want you to feel free to chat with each other, let everybody know who you are, what you do, where you're calling in from today. And in the Q&A console, I want you to type in any questions that come up for you as the webinar goes along. If you're having any technical difficulties, I also want you to put that into the Q&A console. We have people ready in the background here to address any of your technical difficulties and help you have a good experience with this webinar. The Q&A console also is the place during the webinar as you're listening to our speakers. If any questions come to mind, you just stick them in there. We actually have people working in the background here. They'll be answering your questions in real time. And some of those questions will also be part of our Q&A session that we have towards the end of today's webinar. Before you ask in the Q&A, let me just say that the recording for today's webinar, the slides, and actually the report that's kind of featured as part of this webinar, all of these things are going to be on the SAMHSA website. So we will be putting the URL for the SAMHSA website into the chat for you to be looking at, and you can link to it whenever. And the recording of this webinar and the slides will be sent to, the URL for these things on the SAMHSA site will be sent to everybody who registered for this webinar. So you will get the slides, you will get the recording. A few other things. So some of you submitted very thoughtful questions as part of when you registered for this thing. And we have given your questions to our speakers and panel members today. So many of your questions will be answered during the presentation, but if you don't hear the answer to your question, please do use the Q&A and go ahead and ask us in there, and we'll be sure to respond to you. And as I mentioned, we'll have a live Q&A at the end of this, towards the end of this webinar, so that we'll also have time to talk to the panelists and have them address your questions. And last but not least, if we don't get to your questions, because we only have an hour today and we have a lot to cover, we will email you back. Your questions are important to us. We'll email you and we'll respond to your questions over email. So with that, I'd like to talk a little bit about this webinar and where it fits within the overall Center for Financing Reform and Innovation series. Emma, if you can go to the next slide. Oh, the slide after that. So the Center for financing reform and innovations contract is a SAMHSA contract with WestAT. And it's kind of it's a super fun contract because we look at all kinds of things that relate to behavioral health and financing. And usually, this is what makes it really cool as being part of this leadership team, is that there are topics that are very relevant to what's going on across the nation. These are questions that are being asked and issues that are at the heart of what a lot of people are thinking about. So things like, how do you finance coordinated specialty care without the mental health block grant set aside? What are innovative ways to use value-based payment for substance abuse disorders treatment? We actually have 18 current projects. And if the SAMHSA website now has a CFRI, we call it CFRI for short. We have a CFRI website where you can see the reports that we've already put out. But in addition, you can see all of the really neat things we're doing and all of the reports that will be coming out soon. So I encourage you to go look at that website. Excuse me. And that'll also be in the chat. And so with that, I would like to now turn the microphone to Dr. Karen Phillips. Dr. Phillips is the Deputy Director of SAMHSA's Center for Substance Abuse Treatment. She was previously at the National Institute of Drug Abuse and the National Institute of Health. And her research and practice focus particularly on improving access and quality of care for individuals with substance abuse disorders. So with that, Dr. Phillips, you now have the microphone.
Thank you so much. Good afternoon, everyone, and thank you for joining us today. I feel that this is a really important webinar on Medicaid coverage of medications to treat alcohol and opioid use disorders and reverse opioid overdose. As mentioned, my name is Karen Phillips, and I am the Deputy Director at the Center for Substance Abuse Treatment. It is my pleasure to introduce this session. Medication is an essential component in the evidence-based treatment of substance use disorders. The U.S. Food and Drug Administration has approved several medications for the treatment of alcohol use disorder, opioid use disorder, and reversal of opioid overdose, all of which are covered by Medicaid. However, there remains a significant gap between Medicaid beneficiaries who need substance use disorder treatment and those who receive it. It is critical that states and jurisdictions have comprehensive coverage of these medications and the approaches to make them accessible to individuals who need them. The report presented today provides information on the availability of and access to medications for treating ongoing alcohol use disorder and opioid use disorder, and reversing an opioid overdose within state Medicaid plans. This work builds on two prior Substance Abuse and Mental Health Service Administration reports. The current report provides an update on the present state of coverage and availability of these treatments to Medicaid beneficiaries. It highlights progress in terms of expanded coverage since the 2018 report, as well as ongoing barriers and challenges. Some key facts from the report. Medicaid is the single largest payer of behavioral health services in the United States. As of April 2023, more than 87 million Americans were enrolled in Medicaid. Approximately 20.6% of Medicaid beneficiaries aged 12 and older met criteria for having a substance use disorder, compared to 14.8% of privately insured individuals, making understanding Medicaid's role crucial. The proportion of states covering medications to treat alcohol and opioid use disorders has grown since 2018. This has been achieved through policy and practice changes. However, policy challenges remain. These include implementation of the requirements of the MATE Act, which seeks to expand education on SUDs, billing requirements, privacy laws, and concerns about oversight. Patient-level barriers also remain. These include limited transportation resources and lack of accessible providers. There are also cultural barriers and lack of trust in the healthcare institutions. Stigma poses a significant barrier to seeking and completing treatment for substance use disorders. In her presentation today, Dr. O'Brien will provide an overview of the current landscape of Medicaid coverage for these medications. She'll share details on coverage rates, limitations, and availability issues that persist in many states. Dr. O'Brien will also highlight some innovative approaches states are taking, such as crisis response teams and mobile health clinics, to expand access to underserved and vulnerable populations. We look forward to an engaging and thought-provoking discussion on this critical topic. Now I'd like to hand things back over to Dr. Shoma Ghosh.
Thank you, Karen. We appreciate you being here and presenting to us. We really do. So I am in a moment going to turn it over to Peggy O'Brien, who will highlight some of the upcoming report, or actually the report is out on the website. So go look in your chat, it'll be there, the URL for it. And I have to say, I kind of am loving the chat. You guys follow directions really well. And I love that you guys are all putting like stuff into the chat. I'm looking at it, so I'm loving it. So keep going, but while we do that, so our next speaker is Peggy O'Brien. Dr. O'Brien is a social science analyst in the Office of Evaluation at SAMHSA's Center for Behavioral Health Statistics and Quality. That's pronounced CBISC for short. Her behavioral health work has encompassed clinical practice, research, and policy, and she has extensive experience related to behavioral health service delivery, access, and financing. I've worked with Peggy over the past probably decade. And yeah, I always enjoy listening to her speak. So with that, go ahead, Peggy.
Thank you, Shoma. Thanks. I'm Peggy O'Brien from CBISC, and I'm pleased to be able to briefly share a high-level overview of this very important report. I encourage all of you to read it for more detail than I'm going to be able to provide today. I'm going to assume that if you're here, you are very familiar with the nature of substance use disorders, including alcohol and opioid use disorders, and the tolls they take each year in our country. This report focuses on the extent to which reimbursement is available under state Medicaid programs for medications that treat AUD and OUD and medications that are used to reverse opioid overdose, as well as highlighting a handful of innovative models. Next slide, please. So this slide displays both the generic and brand names for FDA-approved medications to treat those disorders and to reverse opioid overdose. Next slide, please. Over the past many years, multiple approaches have been taken to promote access to these medications. Each is addressed in greater detail in the report, but policies designed to increase access have included the enactment of provisions of the Support Act requiring reimbursement for all OUD medications under state Medicaid programs, the Medicaid drug rebate program designed to reduce costs to Medicaid for those medications, Medicaid expansion under the Patient Protection and Affordable Care Act, which has allowed many more individuals and families in the United States to obtain health insurance that covers these life-saving medications. And Medicaid Section 1115 SUD demonstration waivers, which support innovation and enhance the provision of access to medication treatment in at least 36 jurisdictions that have received such waivers. Other policies address specific barriers to accessing the medication. Examples include removal of the so-called X waiver for prescribing buprenorphine and other changes that facilitate its prescribing. Changes in how methadone may be accessed, including the ability to take home more doses. Other flexibilities introduced during the COVID public health emergency, allowing increased access to OUD medications via telehealth, and many changes to state and federal laws and policies designed to facilitate access to naloxone for overdose prevention, or reversal rather, sorry. Next slide, please. Excuse me. Other challenges to accessing SUD services have included billing requirements, such as limits remaining in some state Medicaid programs on reimbursement for both a primary and behavioral health visit in the same day. The ability to share data across providers due to data exchange regulations, and highly varied state requirements related to professional licensure and certification that may affect the availability of SUD services. The report addresses each of these policies in greater detail. Next slide, please. There are also ongoing efforts to improve the integration of treatment for SUDs within different settings in the healthcare system. Some examples include integration of both mental and substance use disorder treatment and recovery services in certified community behavioral health clinics, or CCBHCs, including a requirement for provision of access to medication treatment. Offering SUD treatment in federally qualified health centers, or FQHCs, and encouraging opioid treatment programs, or OTPs, to expand medication offerings beyond methadone. Next slide, please. So now I'm going to move on to some of the highlights of the report specific to state Medicaid program reimbursement for the medications. The methodology is explained in detail in the report, so I will just note that our contractor undertook a comprehensive review of publicly available sources to determine coverage and limitations. Those limitations would include such things as preferred drug lists, prior authorization requirements, and quantity or maximum daily dose limits. I also will note that comparisons of this report to the 2018 report are generally not advised due to differences in methodology, particularly related to how review of Medicaid MCO documents was done. Excuse me. At a high level, this 2024 report, though, found that large proportions of state fee-for-service Medicaid programs and state Medicaid managed care organizations do cover medications to treat AUD and OUD and to reverse opioid overdose. Next slide, please. This slide depicts the number of state Medicaid fee-for-service programs identified as covering different types of medications for AUD and OUD treatment, with methadone clearly covered now in all states under fee-for-service Medicaid, some form of buprenorphine covered in all states or territories where it could be ascertained, and nearly complete coverage of some form of naltrexone. As you can see, coverage was less likely to be identified for the AUD medications, acamprosate and disulfiram, although naltrexone, which may be used for either AUD or OUD, is well covered. Also, when I refer to states, I include in there the District of Columbia and 2 territories, Puerto Rico and the U.S. Virgin Islands. Next slide, please. This slide depicts the number of states with Medicaid MCOs identified as covering medications for OUD and AUD treatment. As you can see, MCO coverage is fairly consistent across the different medications. Next slide, please. As I noted on the previous slides, acamprosate and disulfiram have the lowest observed coverage rates for state Medicaid fee-for-service and managed care beneficiaries. However, when covered, those states that cover them are unlikely to require prior authorization or have quantity limitations. Additionally, oral and injectable naltrexone are widely covered and unlikely to require prior authorization or be subject to quantity limits. Next slide, please. Buprenorphine monoproduct, or buprenorphine alone without naloxone, is very widely covered. Injectable buprenorphine is covered in fewer states, but as we know, the longer an injectable is on the market, the more likely it is to be covered by more states. The 2 medications do have similar rates of preferred status among states with coverage. Buprenorphine naloxone coverage is nearly complete and has preferred drug status in many states. Coverage of methadone is consistent across Medicaid fee-for-service and managed care plans and is nearly complete. Next slide, please. Moving on to the medications for opioid overdose, naloxone is widely covered by state Medicaid programs. Additionally, the March 2023 approval of naloxone nasal spray for over-the-counter sale will likely impact state-level regulations governing naloxone sale in the future, as well as its availability and its cost to Medicaid beneficiaries. Next slide, please. In addition to describing information on Medicaid coverage for these medications by state, the report addresses a number of innovative models that focus primarily on expanding access to OUD medication for underserved populations and making more effective use of existing systems. These models were selected through discussions with subject matter experts at SAMHSA and the National Association of State Alcohol and Drug Abuse Directors, or NASADAD. Focusing on models that are replicable and reflect systemic factors shared by many states. Our panel discussion will delve into two of these innovative models. Next slide, please. Finally, the need for wide access to SUD treatment, or SUD treatment, is critical, and the effectiveness of medications for treating AUD and OUD and the life-saving benefits of naloxone are well established. States have made considerable progress in expanding access to medications through regulatory vehicles that encourage innovation and coverage, integrating SUD treatment into more provider settings, and using novel means of service delivery such as telehealth or mobile access. Moreover, the findings in the report show promising growth in the availability of these medications and the removal of reimbursement limitations. However, continued efforts to improve access to the medications that are used to treat AUD and OUD and to reverse opioid overdose remain very necessary. With that, I will turn it back over to Shoma. Next slide, please.
Thank you, Peggy. I can tell you wanted to cough like I coughed at the beginning there. I could tell it was coming. But thank you, that was great. I have to say, like, next time we do this chat, I'm going to have an icebreaker question, like something like, where's the weather where you're at or something, because I'm loving it, but I feel like I want to know more. The next time for one of these next webinars, I'm going to do that. So next up, we have kind of a treat. We're going to put together, we have a panel together. Melanie Witter is our is going to be the panel moderator for this. Melanie is the Deputy Executive Director for the National Association of State Alcohol and Drug Abuse Directors, for short NASADAD. Everything has an acronym. So Melanie is great. I've worked with Melanie many times over many of these reports on CFRI. I love Melanie. Before she was at NASADAD, she was in Illinois. She was a single state authority in Illinois for alcohol and other drug services. And today I am very pleased to have Melanie as part of this panel, and she will introduce the other panelists now. Over to you, Melanie.
Okay, thank you so much, Shoma. So good afternoon, everyone, and I am very pleased to be facilitating this session on two innovative programs that you heard are highlighted in the report that was just summarized for you. So first, I would like to introduce our speakers for today, our presenters. Ariana Campbell is an emergency and addiction medicine physician assistant with more than 24 years of experience. She works in a clinical capacity in emergency and addiction medicine at the Marshall Medical Center in Placeville, California, as well as she also works at the VA in Sacramento, California. She serves as director and co-principal investigator for the National Bridge Network and the California Bridge Program, which you're going to hear a little bit about today. And she is co-founder of both of those efforts. The next presenter I'd like to introduce to you is Misha Hillis. And Misha presently works for Rutgers University Behavioral Health Care, where he provides services and manages community programs that serve at-risk populations, including individuals with mental and substance use disorders. His current focus is on peer-driven reentry services, and you're going to hear about one of those today, the Intensive Recovery Treatment Support Program that addresses the opioid epidemic in New Jersey. And he also manages several other community outreach and prison-based programs. So to get us started, I'd first like to ask our two presenters, starting with Ariana, to briefly describe your programs and specifically the populations that you serve through these efforts. So Ariana?
Yeah, sure. Well, thank you. I'm very grateful to be here. Thank you to SAMHSA, to CFRI, NASADAD for giving me this opportunity to highlight the work of Bridge and California Bridge specifically. So for context, California Bridge, it's a statewide program. It's been supported by the Department of Healthcare Services to improve emergency department treatment of substance use disorders. And that's through implementation of patient navigators and evidence-based treatment protocols. So we have a few core elements, and that includes rapid access to low barrier treatment meaning medications. We are obsessed in getting our patients to medications that we know will save their, can save their life, as we've already talked about. So we also are very, very obsessed with connecting folks to care and community. So what that means is making sure folks get low threshold follow-up and community resources. And then we really promote this culture of harm reduction in all of our emergency departments and all of these sites we're supporting. So who are we serving? Well, more than 70% of the patients we're serving are Medi-Cal beneficiaries. If you look at the article that we just published in JAMA yesterday, I'm very proud of that, you'll see that there was 85% who were Medi-Cal beneficiaries. We call in Medicaid in California, we call Medi-Cal. So we do recognize, the thought behind this program is we recognize EMTALA, so the Emergency Medical Treatment and Active Labor Act, means that we're the open door. No shirt, no shoes, you get service. If you don't come in with all the right ID, et cetera, you get service. So we are in a point where we can leverage that to provide care to vulnerable populations. And we know that there's a high prevalence of substance use disorder in the patients we serve. About 1 in 7 in California of people who come to the emergency department have a co-occurring substance use disorder. So we just know it's very important to leverage emergency departments to give access to treatment. So we know that last year there was more than 11,000 overdose deaths, more than 20,000 deaths related to excessive alcohol use as well in California. And we know that there's more than 1 million people that with a diagnosis of a substance use disorder coming into these California emergency departments yearly. So we have been training our doctors, our PAs, our nurse practitioners, how to give buprenorphine for opioid use disorder, how to initiate naltrexone and gabapentin for alcohol use disorder. And we also provide in-hand naloxone, where we really are thinking about how can we cut overdose deaths in half? That's what we want to do. So we facilitated funding for navigators in California. And then again, our navigators have provided almost 280,000 visits in emergency departments in California. So we've been able to scale rapidly and give buprenorphine specifically in almost 90,000 encounters. So again, we were able to scale rapidly because we are so focused on decreasing overdose deaths.
Wonderful. Thank you so much for that brief overview. I'd like to turn it over to Misha now to explain his program.
Sure, thank you. And it's such an honor to be here and be able to talk about the tremendous work that staff are doing in the IRTS program. So the IRTS program is an intensive recovery treatment support program. And it is exclusively focused on individuals who are incarcerated in state prisons throughout New Jersey. We are in every state prison, and we provide services in every county in the state upon release. And so it is a recovery and wellness focused program. It's based off of the 8 domains of wellness, Dr. Margaret Swarbrick's work. And so we engage with folks prior to their release from incarceration, at least 30 to 60 days before, and up to 12 months in the community once they're released. And the primary folks providing that engagement and support are peer support navigators. So they're folks with lived experience around recovery from substance use disorder, or they were incarcerated themselves and successful reentry, and they use that lived experience to come alongside someone who is now going through a similar process, being released back into to the community after a period of incarceration. And so again, it's pre and post recovery. And the goal of this program was really to address the opioid crisis that was happening in New Jersey, and has been for some time, across the country as well. So in January of 2018, the program began. We've been able to serve 3,000 individuals. And the way that we do that, again, is primarily through peer support with nursing care and case management as adjunct services to that. And through the CTI model as well, which is critical time intervention. So it's very intensive initially. We're meeting with folks a minimum of 1 time per week face-to-face when they're first released in the community. And then after their first 4 months, it's twice a month, and their last 4 months, which would make up a year in the community, it would be 1 time per month. And so the goal was really to reduce recidivism and reduce overdose. And one of the ways we've really targeted doing that is through MOUD and MAUD, as well as, I'm very proud to say, liberal distribution of Narcan. So we came alongside the DOC. Folks are prescribed the full availability of medications, MOUD and MAUD, while incarcerated. So they leave already on that medication. And Medicaid has played a tremendously valuable role in ensuring that they are able to continue to receive that once in the community. So we connect them with care, and we make sure that's a seamless process. And I'm happy to say that thanks to lots of efforts and changes here in the state locally, we've been able to connect everyone seeking MOUD or MAUD in the community to treatment and a provider and sustain that. So that's kind of an overview of the model. Again, we've served over 3,000 folks across the state, and we've been able to maintain less than a 2.5% rate of recidivism and less than a 1% overdose rate for folks engaged in the program.
Great, thank you. Amisha, I think we'll stick with you now for the next question, then we'll turn it over to Ariana. Can you explain how your programs are funded? I know you both rely on Medicaid. You have a high rate of Medicaid eligible individuals in your program, but what other funding sources did you draw upon to both develop your programs and then also to sustain your programs? Because everyone's always very concerned about sustainability.
Absolutely. So we've had the opportunity, the IRTS program is really a partnership between Rutgers University, but our funding is really from the Division of Mental Health and Addiction Services, as well as the New Jersey Department of Corrections. And so both entities really saw the value of providing, best practices, peer support, evidence-based practices, MOUD, both pre-release and continuing that and ensuring that continuity post-release. And so primarily our funding is from both of those entities. The role that Medicaid has really played around that, though, of course, is paying for medications and treatment once someone is in the community, as well as transportation. So Medicaid transportation in New Jersey, it's a very interesting mix of very urban, a lot of suburban, and very rural areas. And so being able for someone to get to a provider, Medicaid transportation has played a huge role in that. But for us, the primary funding for the program is through the state's Division of Mental Health and Addiction Services and New Jersey's Department of Corrections.
Great. And Ariana, can you tell us a little bit about your funding?
Yeah, sure. So the work that we're doing has been, it's really supported by the Department of Healthcare Services in California, and they oversee Medi-Cal in California. So we received initially some state opioid response funds in order to start this work, but we were also able to work with partners in the state to even get a line item in, the state budget, for example, to support navigators. More than, I already mentioned it, but more than 70% of our patients do have Medi-Cal. And in California, Medi-Cal actually allows emergency access. So this is really crucial for our patients to get their medications, like we've already discussed, and make sure that they can follow up. But also, they're pretty innovative in California. So there's been a really ambitious reform going on right now in California with our Medi-Cal services. So they're looking at the community health worker benefit. They're working on that to ensure that we can bill for the services of our navigators who do really essential work. There's something called CalAIM, and that's setting out to innovate care for vulnerable populations. Also, the work is supported in emergency departments. There's Medicare came up with a G2213 code. This is a code to reimburse like a higher level of reimbursement to initiate folks on buprenorphine in emergency departments. And our Medi-Cal took that on as a reimbursable code. So that was really supportive. And then our Department of Healthcare Services has also prioritized all this care. So they're making follow-up after from the emergency department, one of the top 6 priorities for Medi-Cal. So that's for a strategy, that's a metric for counties and health plans. So all of those things are really, it's complex. We have to work together to really prioritize this right now. I can tell you in the work we're doing across the country, majority of the patients have Medicaid. So this is incredibly important to talk about in terms of access to treatment. I will say that we have navigators in California, and a lot of sites have chosen to sustain their navigator because navigators work and are sustained because they decrease readmissions, they decrease length of stay. There's a lot of evidence, but we definitely know that these other supports in terms of sustainability, making sure that these are reimbursable services, that's extremely important. So we've had a great partnership with the state on that.
Great, thank you very much. So I would like to hear from both of you a little bit about any initial problems or barriers you had in establishing both of your very innovative programs, but more importantly, how you overcame those challenges, and then any lessons learned that you can share with our audience. That would be extremely helpful because others may want to replicate your approach in their own home communities and states. So Ariana, do you mind tackling that first?
Sure. I mean, I think the story is the same. Like when fentanyl came on scene, it was just this enormous, we had to be very flexible in how we were addressing that. We also had to send the right message. So people pick up on our messaging. So if people think that treatment doesn't work, they're not going to access treatment. So we really have to be mindful about how we talk about treatment. And we had to maintain our positivity and like this works so that patients can really get care. So I'll say that I do have to acknowledge that funding. So grant funding, we are a mission-driven, nonprofit grant-funded organization. And it's challenging for 1- and 2-year grant cycles to stay mission-driven, to stay really hyper-focused on decreasing mortality, decreasing overdose deaths. So, I would say always an issue. This is embedded in anywhere from just our communities to our policymakers to our patients is stigma. And having some intention on addressing stigma at all levels is really important. I always say, so we know that 94%, 95% of people with a substance use disorder are not accessing treatment. Could you imagine if that was like hypertension or diabetes, and all of the things we would do to educate people on treatment, to really like make sure people had access, just to remove all the barriers? Well, that's what we have to do right now for this. And so we're looking at every little thing to reduce those barriers. And of course, that's challenging given grant funding structures, et cetera. So that's been challenging, but there's a lot of hope, and we're set on decreasing these overdose deaths.
Thank you. Misha, could you talk a little bit about some of your challenges and how you've solved them and any lessons?
Sure. So I was going to talk about stigma. Ariana did such a great job kind of outlining that. I can tell you 2 areas where I would identify that as our major challenge. First one, and again, I'm referencing the start of the program, 2018. So over the last 6 years, we've seen a lot of positive improvement, but it's just stigma around someone being on MOUD or seeking it. Oftentimes, pardon the expression, but folks may be told that they're not, quote, clean if they are on an MOUD. And I think we've done tremendous amounts of education, not just externally, but also internally with staff, making sure that everyone really understands how life-saving these medications are, and really promoting them and helping folks understand how it can be a critical part of the components of your treatment. And so that was a huge piece of what we did, as well as really helping folks understand that use of peer navigators, those with lived experience, is an evidence-based practice. It's a best practice. And really helping folks understand the power of peer support. And so those were two areas where we really faced some initial challenges. But I think that over time and really folks seeing how effective the work could be done and how life-saving MOUD is really shifted a lot of the perceptions around that. But those were really two of the major challenges. And of course, you know, stigma is something we must continue to address. So that work is ongoing.
Okay, thank you so much. Well, and both of you have talked about the importance of navigators in your program and the important role they play. So that seems to be a common theme and maybe lesson in terms of how valuable they really are. Well, I have so many more questions I'd love to ask you, but now it is time for question and answers from our audience today. So I'm going to turn it over to Eliane Rosenfeld, and she is going to facilitate our Q&A session.
Sure, thank you so much. I appreciate that. So Mike, I have a couple of questions for you around the funding of, and Ariana as well, of those peer navigators, and questions around Medicaid billing for that. So Micah, would you be able to go first about how those are funded and just a little bit more detail?
Sure. So those positions are funded through opioid crisis funding initially. That was how it was initially funded. In an ongoing basis, that is really funded through, you know, more specific budget funding from the Division of Mental Health Addiction Services, as well as specific funding from the New Jersey Department of Corrections for navigators to come in and do work pre-release for DOC, and post-release, you know, DMHAS, our state continues to fund those services. So we're not presently billing Medicaid specifically for peer services. Medicaid has been tremendous for us in, you know, access to care and paying for treatment, MOUD, MAUD for participants in the program.
Great. And Ariana, I know you covered it a little bit, but if you want to reiterate.
Well, I mean, it's mixed right now. So we are working on the community health worker benefit in California to reimburse services for navigators. I can tell you in my own hospital, in my own clinic, that's our model is, and we call them substance use navigators. And though having that peer component is definitely, you know, we encourage that. Some navigators have been sustained just by their hospital system because they increase follow-up after emergency department visits. That there's a lot of evidence about that, you know, and then they reduce hospital length of stay. So I can tell you, my navigator, we watch this. This is great for all hospitals to look at. Look at your prevalence of substance use disorder. Look at your prevalence of substance use disorder for admissions and for readmissions. And what we found is our navigator, who's employed by the hospital, paid for by the hospital, part of our emergency department budget, her work decreases readmission risk at least fivefold. So those kinds of things are really important to get out there. And we just, you know, there's a lot of evidence even from our NavStar partners out in Maryland who found that they reduce costs for the hospital overall. So from my hospital to more broad literature, definitely we see decreased readmissions, decreased emergency department visits, decreased costs. So that's one way, is just making sure that hospitals know their value. But getting that CHW benefit, the community health worker benefit, to reimburse is also very important. And we need to make sure we have that for hospitals who may not have, you know, this is a newer position. They're still trying to find ways to sustain it and have more narrow margins. So I think it's important to have that. We're also looking at there's some enhanced care funding in California that we're looking at vulnerable populations, and we're also looking at how we can utilize those funds to sustain navigators. So all of this is being looked at right now, and again, looking at some of that follow-up after. I would love it if we had more broader, broader uptake of the importance of these navigators. If, you know, certain federal entities, maybe the Joint Commission, maybe, you know, we're really encouraging this as a best practice because we know that it saves lives. We know that improves processes, improves follow-up for vulnerable populations.
Wonderful, thank you. Now, Mike, I had some questions about kind of the collaboration that you have with the Department of Corrections, and then also to follow up on that two-pronged question, treatment available for folks who are currently incarcerated, not in the period pre-release. So if you can speak on either of those top questions.
Sure. So the New Jersey Department of Corrections was very progressive. And again, I'm referencing back 2017, 2018 in implementing MOUD and MAUD medications into the prison system. So that included the full gamut of it. Could be Sublocade, could be buprenorphine, methadone, all of those were available. And so we work closely in collaborating with them. And one of the reasons the IRTS program came into existence was because they didn't want to provide substance use treatment services, MOUD, MAUD behind the walls, and then not know what sort of follow-up would occur after that. And that was one of the primary reasons the program began. So Dr. Caldani from New Jersey Department of Corrections was one of the initial folks who came forward with the idea of IRTS. He partnered with Rutgers and partnered with the State Division of Mental Health Addiction Services, and that's really how the program began. So they have always been at the table from the very beginning, and very committed to ensuring continuity of care. I would also add to that, we also have access to their electronic medical record while someone's incarcerated, which enables us to coordinate care pre and post release as well. And our program is responsible for substance use treatment follow-up appointments, and they organize and arrange aftercare for healthcare appointments and mental health. And so everyone comes together to plan that.
Well, that's pretty incredible. Thank you for sharing that.
Sure.
Ariana, there's a question for you about how are the substance use navigators trained and what does that process look like?
So I'm very proud of this. So we train our substance use navigators in harm reduction as like a foundation. I always say, like, who's answering your phone? Like all the people on this, in this webinar, who answers your phone? Who's the first person that patients talk to or that your clients talk to? That person should be a harm reductionist by nature, should know appropriate language, know how to talk to people who use drugs, people who are struggling with alcohol. So we train our navigators. So actually California Bridge has done quite a bit of work. We have a whole wonderful section of people, a lot of our mentors. We have navigators who serve as mentors, navigators with lived experience, navigators who have been doing this work, and they train other navigators. So we have a whole series of trainings that our navigators will embark in. And then we also connect our navigators through, they can chat. They have this like Slack workspace where they chat all the time. And so it's an ongoing learning process because things happen at 2 a.m. and they can hop on and see what other navigators across the state are doing. We have more than 300 navigators in California. There's probably many more than that. Like my clinics are staffed by navigators too. So what happens if we train them all in harm reduction, right? They're trained also being obsessed with getting people to low threshold treatment medications. So they have training in medications and really direct people to this medication first approach. And they are trained in motivational interviewing. So know how to talk to people who use drugs, know how to move people, through this contemplation phases. So, the work that my navigator does, I can tell you, before I see a patient, I sometimes try to race her because I'm trying to get to somebody who's coming in for treatment to make sure we engage them. And she's already done the hard work. She's talked to them. She's given them hope. She's told them that we're going to smooth everything out in order to create, to make it, I always say, like, get rid of all of those barriers so the person can just get the treatment that they need and deserve, and then make it to follow up very quickly. And that's what our navigators are trained in. It's not just motivational interviewing. It's also how to navigate these systems of care, how to deal with pharmacies, how to really iron out all of the wrinkles so that a person just gets the treatment that they need.
Thank you so much for that. So one of the questions we have, and I don't know if it could potentially be for Peggy or Rob, questions about, is there a time limit for a client to be on MOUD if they are served by Medicaid?
I can start an answer to that, and if Rob wants to chime in, he can. Every state is different, and ideally, people would have access to the medications as long as they need them. It's hard to generalize because every Medicaid program is unique and reimbursement is unique. So I don't know, Rob, if you have anything that you want to add to that.
Thank you, Peggy, and hello, everyone. I mean, certainly the decision to be on medications for any length of time is a person-centered decision. It's a decision that should be made between the individual and their practitioner. And so many people are on medications for a very long time in life. Others are on medication for a few months, and it depends on their circumstances, their response to medication, and many others. And certainly, many programs and grants and other systems support that approach.
Rob, I'm not just asking this because I like to hear you speak, but do you want to introduce yourself?
Thank you. Hello, everyone. My name is Rob Bailey. I'm a primary care physician and senior advisor in the Center for Substance Abuse Treatment. And I'm sorry I didn't introduce myself before.
No, I'm sorry I didn't ask you to. I appreciate you taking the time to answer these questions. So we had a number of questions when folks were registering about how are we dealing with folks who are under 18? So Ariana, how does the CA Bridge deal with patients who are teenagers coming in?
Well, buprenorphine is FDA approved for age 16 and up. But we also really, I mean, like I said, the nice thing about the emergency department is you could come in at the age of 14, and we actually have done an entire youth initiative. So Amy Moulon, one of my partners there at Bridge, one of the co-principal investigators, she did a lot of work actually in pediatric emergency departments to educate and to provide access for our pediatric patients. I mean, we all know, like, by definition, addiction's a pediatric disease, right? So, onset is typically like aged anywhere between 12 and 14. And there's this 10 to 12 year gap in treatment. So so that's a lot of the work of our navigators. I can tell you there's one story where we were trying to find care for a 14-year-old, and we were finding barriers in the outpatient world. We will, like, when I say we, my hospital will initiate people. There are different state laws regarding consent, minor consent. All of this should be looked at. Often it is a parent bringing in a 14 or 15-year-old or 16-year-old to get treatment. And so we do some shared decision making. So this is FDA approved. If this is buprenorphine, FDA approved for age 16 and up. However, given this risk with fentanyl use, this is a medication that can prevent death. And so that conversation we document and can do some shared decision making to initiate treatment. And then for follow-up, we ensure we know our communities who will see our adolescent patients and follow up. And always getting our pediatricians on board. So again, including when we do this for emergency departments, it's not just general emergency departments, it's some of our pediatric centers as well.
Thank you for that. We had a question about potentially what can you do or figure out how to obtain funding or cooperation when a Department of Corrections or when many of the prisons are privatized. And I don't know if you could speak to that at all, Micah.
Sure. So I would encourage to consider taking an approach where the effectiveness of services provided reduce recidivism. And so, that can be challenging, but a lot of entities are dealing with overcrowding and a lot of other challenges. And so, the recidivism rate for our program was less than 2.5%. So that means someone who's engaged in our services has less than a 3% chance of returning to prison. That was over 3 years. We're currently looking at that over a 5-year period. And so engagement in services and treatment, peer support, all of those things reduces recidivism, which reduce costs. So, one way to come at it is that good treatment and good care and access to treatment, MOUD, MAUD, can reduce that crowding, reduce recidivism, and overall help people's well-being in the community. And really coming at it from that perspective can be helpful. I think one of the reasons that we were successful with DOC was because of our success in reducing recidivism and overdose, and also our ability was so effective that they added other programs inside of there to get folks talking about recovery even years or months before their release, not just the last month of release. So I would encourage you to take a perspective of, all those things I just talked about and really look at it from a community wellness, a cost reduction, and connecting people to life-saving medication and treatment.
Thank you for that. And I think this could be a question for anybody here, but maybe particularly Ariana. What are approaches that the CA Bridge program or use when patients are using drugs outside of opioids or alcohol?
Oh, I always say we have something for everybody. So I think really quickly in this work, you just realize people aren't just using one thing. So we have, if you go to bridgetotreatment.org and look at our resources, we have a lot of resources for co-occurring disorders. So really, we have an entire algorithm for alcohol. We are encouraging initiation of naltrexone and gabapentin in emergency departments. We know number needed to treat is just 11 people when we give FDA-approved medications for alcohol use disorder. We don't encourage drug testing in emergency departments. It's not helpful, but we will talk to people about whatever they're using. And we also, this is very patient-centered. So what do you want to do? I say, so what do you want to do? And if somebody is using methamphetamine and fentanyl and want to tackle both, great. I'll talk to them about how we can help them. We give a kickback for withdrawal from methamphetamine. There are not FDA approved medications for stimulant use disorder. However, we know that there are studies that show us there's medications that work. And I talk to my patients about that. I can help you with some of this, depression that is often faced when withdrawing from methamphetamine. And we can support outpatient with contingency management, which is evidence-based. So I think it's really meeting people where they're at, asking them what they want to do, and then decreasing their harm. So, if somebody comes in and they're using multiple substances, I have a lot of patients who fit this category. Most, I would say, then we figure out what they want to do and provide medical treatment for this. So it's just that patient-centered thing. If somebody comes in with diabetes and hypertension, we'll do the same thing. We'll address both and not exclude one or not exclude them from treatment because they struggle with multiple things.
Thank you for that. And I know CA Bridge has a website with many, many resources. Does it include information about how to tackle folks who have multiple use disorders and that type of conversation?
Yeah, a lot of it is just, we talk about this approach to the patient. So a lot of this is in our resources. We have, if you go to our website, you're going to see how passionate we are about innovating our healthcare system to address substance use disorders and to meet people where they're at. And so we say there's something for everyone, and it all makes sense when you do patient-centered care. But yes, we actually have fellowships for clinicians in terms of addressing alcohol use disorder. We have innovative practices for how we approach methamphetamine use, and stimulant use disorder. So yeah, there's, like I said, there's something for everything. And a lot of this, again, we have so much prevalence of substance use disorders in our emergency departments. When you take this as just like another tool in your toolkit, more than half of the patients I'm starting on medications for addiction treatment. So for alcohol use disorder, opioid use disorder, stimulant use disorder, they come in for a different reason. And I offer this as treatment to, maybe they come in for an abscess and have been injecting drugs. We'll talk about it. I offer them a whole spectrum. So harm reduction, can I get naloxone in your hand right now, to treatment? And it's amazing when you address it just like any other medical problem, how effective that is. Most people actually accept some sort of either harm reduction or treatment. And my follow-up rate, you'd think the follow-up rate would be dismal because they didn't come in seeking treatment for their substance use disorder. But in my hospital, we've always maintained more than 70% follow-up for our patients, even those who come in for a different reason. So, which just shows, people really do want access to treatment. We just need to provide it in a manner that works for them.
Thank you so much for that. Well, we have a bunch of other questions, but we've run out of time. So I'm going to turn it over to Shoma to end things for us.
Yes, so thank you. This has been inspirational, really. The speakers and the panelists, thank you so much for coming to this webinar. And I have to say, the audience, I love the participation and the questions. As Eliana mentioned, there's we see lots of questions and we're so heartened that you're engaged with this topic. So we will respond to you. Look out for an email from us. You'll get the slides and the webinar. And thank you. And until we have our next CFRI webinar, have a very nice day. Thank you, everybody.
Thank you for having me. Thanks.
Thank you.